Welcome to the third video of the Otolaryngology Sleep Disorders module. In this video, we will be identifying the important anatomical structures of the upper airway that can contribute to sleep disorders, most specifically sleep apnea. We will also cover the physical exam of these anatomical areas. This is critically important when deciding whether the patient is a candidate for any surgical intervention. There are four key areas that we will be discussing in this video. These are general appearance, nasal anatomy, oral and oropharyngeal anatomy, and pharyngeal and hypopharyngeal anatomy. Let's begin with general appearance. Patients presenting to the outpatient clinic should have vital signs taken during their visit. The most important vital sign in a patient complaining of a sleep disorder is blood pressure. Hypertension is correlated with obstructive sleep apnea severity. BMI should also be calculated. BMI greater than 27.8 in men and 27.3 in women is associated with higher rates of sleep apnea. Larger neck circumference, measured at the level of the cricothyroid membrane, is also associated with increased rates of obstructive sleep apnea, specifically greater than 17 inches in men and 16 inches in women. Evidence of craniofacial abnormalities in mandible position should be identified. When the patient is in the Frankfurt plane, a line drawn from the inferior orbital rim to the superior rim of the external auditory canal is parallel to the floor, retrognathia can be identified. A line connecting the vermilion border of the lower lip to the pagonian should be perpendicular to the Frankfurt plane. If the mandible protrudes more than 2 millimeters behind this line, it is considered retrognathic. As part of a complete head and neck exam, the next important anatomical area to assess is the nasal cavity. The external nasal appearance is examined for asymmetry of the nostrils and collapse of the external nasal valve. A nasal speculum should be used to assess turbinate size, the position of the cartilaginous and bony septum, and presence of obstruction, such as a mass or lesion. The most common site of obstruction in the nose is the internal nasal valve, which is comprised of the nasal septum, the head of the inferior turbinate, and the caudal border of the upper lateral cartilage. The caudal maneuver, in which one or two fingers are used to pull laterally on the cheek, and modified caudal maneuver, in which a cotton-tipped applicator is used to push the nasal wall laterally, can help to determine whether surgical correction of the internal nasal valve will improve the subjective nasal airway. Nasal endoscopy with nasopharyngoscopy is often used to better assess the septum and turbinates. It can also determine if polyps, adenoid hypertrophy, internal valve collapse, or choanal obstruction is present. Next, it is important to evaluate the oral cavity and oropharynx. Specifically, this involves assessment of the tonsils, tongue, and palate. The following images were taken from Friedman et al.'s article, Clinical Staging for Sleep Disordered Breathing, which was published in the July 2002 issue of Otolaryngology Head and Neck Surgery. When the mouth is first inspected, the two most important anatomical areas to notice are tonsil size and position of the tongue. As you most likely already know, tonsil size is graded on a scale of 1 to 4, with each number correlating to 1/4 of the way from the tonsil pillars to the midline. Mallampati or Friedman score is commonly used to describe the position of the tongue compared to the palate. The two scales are similar, with Mallampati scored with the tongue protruded out of the mouth and the Friedman scored with the tongue sitting within the mouth. Here are drawings of the Friedman score grading scale. As you can see, in grade 1, you can see the entire uvula and tonsils. In grade 4, only the hard palate is visible. Friedman and his colleagues combined these two parameters with BMI to develop the Friedman staging system. This score predicts a patient's likelihood to improve after uvulopalatopharyngoplasty. Stage 1 predicts the largest amount of improvement. Besides the Friedman score, note the length and thickness of the uvula. It is important to understand the origin and insertion of the other soft palate muscles, which include the palatoglossus, levator veli palatini, and tensor veli palatini. Finally, we assess the anatomy of the pharynx and hypopharynx. This includes the base of the tongue, lingual tonsils, and the shape of the epiglottis. In the midline, the foramen cecum divides the oral tongue from the base of tongue. Laterally, the location of the neurovascular insertion cannot be directly visualized, but should be understood. The hypoglossal nerve, which provides motor innervation to the tongue, and the lingual artery, which provides blood flow, insert here. Because the pharynx and hypopharynx are not easily visualized, flexible laryngoscopy via the nasopharynx is used. The size of the lingual tonsils and amount of molecular crowding, as well as the shape of the epiglottis, can be determined. Some patients with obstructive sleep apnea will have an omega-shaped epiglottis, which can contribute to their restricted airway. An inferiorly positioned hyoid bone has also been shown to be associated with obstructive sleep apnea. On flexible laryngoscopy, one can note the difference between anterior, posterior, and circumferential collapse on Mueller maneuver. Mueller maneuver involves inspiring against a closed nose and mouth, which is essentially the opposite of the Valsalva maneuver. The Mueller maneuver allows for the assessment of the vector directions involved in sphincter activity, specifically collapse at the level of the oropharynx or base of tongue. An additional tool that can help to evaluate the sleep disorder patient is DISE, or drug-induced sleep endoscopy. The upper airway is visualized while the patient is under light sedation in a monitored setting. DISE is considered more accurate than the Mueller maneuver. However, it requires more time, monitoring, and the expenses of the operating room. While imaging is not commonly used to assess the upper airway prior to sleep apnea surgery, some practitioners do advocate the use of lateral cephalometric X-rays. It is controversial whether lateral X-ray allows you to calculate the height and length of the tongue, the position of the hyoid bone, the length and thickness of the soft palate, and other parameters, and most surgeons do not use imaging to guide their surgical decision-making. Rarely, MRI or CT scan can be used, but cost, time, and in the case of CT, radiation exposure limits the use of these modalities. In summary, during the physical exam of a patient with a sleep disorder, nasal obstruction should be identified. While correction of this obstruction will not reduce AHI, it can lead to subjective improvement in quality of life as well as improved ability to tolerate CPAP. A simple way to remember the other areas to evaluate during the physical exam is the VOTE system, which stands for velum, oropharyngeal lateral walls, tongue, and epiglottis. This was developed by Dr. Kazarian and co-authors and is used to rate findings during drug-induced sleep endoscopy. In the next video, we will discuss how to interpret a sleep study, which is the most common diagnostic test for sleep apnea.